Welcome to The Explainer. Today, we're essentially putting on our lab coats and diving straight into a microscopic medical investigation. We're looking at a condition that affects billions of people, yet it's often fundamentally misunderstood. We're talking about infectious diarrhea, and we're going to explore this not just as a random set of symptoms, but really from the perspective of the medical laboratory scientist. They're the ultimate medical detectives decoding exactly what goes wrong in the gut at a cellular level.
Okay, let's dive right into today's investigative roadmap. We'll start with the case file, look at normal physiology, then the mechanisms of diarrhea, laboratory diagnostics, treatment protocols, and finally, the overall public health impact.
Part 1. The case file. Let's define the global burden.
So, how do we actually define diarrhea? It sounds like a simple question, right? But in a clinical or laboratory setting, we have to be incredibly precise. Frequent passage of well-formed stool? Well, that doesn't count. What about the normal, loose, kind of pasty stool that healthy, exclusively breastfed infants pass? That doesn't count either. The World Health Organization actually has a very strict working definition for this. It's the passage of 3 or more loose or liquid stools within a 24-hour period, or a stool frequency that's clearly greater than what's normal for that particular individual. That precise clinical threshold is exactly what triggers our medical investigation. And the stakes for this investigation? They literally couldn't be higher. Recent global burden of disease figures put the worldwide case count at well over 2 billion episodes a year. But there's one critical number to keep in mind, and that's 440,000. That is the estimated number of child deaths annually from diarrheal disease. To put that into perspective, that equates to roughly 1,200 children every single day. This immense burden is exactly why laboratory identification and rapid intervention matter so incredibly much to patient outcomes.
Moving on to Part 2, the scene of the crime. We're looking at normal intestinal water absorption.
It's actually fascinating how your gut handles fluid. Every single day, your small intestine handles a massive fluid load, roughly 8 to 9 liters in total from food, drink, and bodily secretions. And almost all of this gets reabsorbed. But the gut doesn't actually pull water directly. The whole process is completely driven by sodium. As sodium enters the intestinal cells, mostly through a transporter called SGLT1, it gets pumped out the other side. This creates an osmotic gradient, which safely pulls the water right across the cells and into the blood. It's an elegant, perfectly balanced system.
Section 3. The modus operandi. Let's look at the mechanisms of infectious diarrhea.
When we compare a healthy gut to an infected one, we see exactly where things go wrong and where that balance tips. Diarrhea, at its absolute simplest, is what happens when the gut either absorbs less water than it should or actively secretes more than it can handle. We're basically looking at 4 main modi operandi, or mechanisms that hijack this system. First up is osmotic, where unabsorbed substances like lactose drag water into the bowel. Second is secretory. The textbook example here is cholera, where a toxin locks the cellular machinery into overdrive, forcing the cells to secrete massive and sometimes fatal amounts of fluid. Third, we have inflammatory. This is caused by bacteria like Salmonella or E. coli that physically breach the epithelial barrier, causing blood and serum to leak directly into the gut. And fourth is motility-related, where transit through the bowel is just simply too fast for any real absorption to occur.
Part 4. The investigation. This is where laboratory diagnostics and evaluation come into play.
When a patient presents with symptoms, clinical evaluation obviously begins with a careful history, but the real forensic evidence is gathered using frontline diagnostic tests right at the lab bench. Microscopy allows scientists to hunt for ova, cysts, and parasites. Stool leukocyte counts and pH levels give us crucial clues about inflammation and malabsorption. We use pathogen cultures to actually grow the specific bacterial culprits, and we rely on advanced tools like enzyme immunoassays and latex agglutination testing to quickly identify specific viral or bacterial antigens.
But what happens if a case just keeps dragging on? If diarrhea is acute, it usually lasts less than 2 weeks. Often it's a viral infection like rotavirus. But if it becomes chronic, meaning it persists for 4 weeks or more, well, laboratory scientists have to deploy a secondary set of deeper investigative tools. We look at serum albumin, fecal alpha-1 antitrypsin, we calculate the anion gap, and sometimes we even rely on an intestinal biopsy. These specialized tests are what help us rule out underlying non-infectious chronic disorders like celiac disease or inflammatory bowel disease.
Section 5. Closing the case with treatment and management protocols.
Now, the absolute most crucial thing to remember here is that the immediate danger is always dehydration.
Step 1 is fluid replacement using a low osmolarity oral rehydration solution, or ORS. Remember that SGLT1 sodium transporter we talked about earlier? ORS is cleverly formulated to utilize that exact same pathway to essentially force water back into the blood. Step 2 for children is zinc supplementation for 10 to 14 days, which actively shortens the duration and severity of the episode. And Step 3 is continued feeding and breastfeeding to support recovery. It's also worth noting that routine antibiotics are generally reserved only for specific indications. They aren't just used as a blanket treatment.
And finally, Section 6, Public Health and Outbreaks, taking this from the lab bench out into the community.
To really ground this in reality, consider this powerful statement from the source material originating from Niger Delta University. Quote, "For us in Nigeria, and particularly here in the Niger Delta, diarrheal disease is not an abstract topic confined to a textbook. In regions that have limited access to safe drinking water and sanitation, active transmission is a daily reality, and seasonal cholera outbreaks require rapid, data-driven community responses."
The incredibly detailed work happening on the lab bench directly dictates public health survival. Laboratory data drives the entire response. By providing rapid organism identification, public health officials know exactly what they're fighting. By testing antimicrobial susceptibility, doctors know exactly which drugs will work and which will fail against a specific local strain. And through real-time outbreak surveillance, communities can mobilize their resources the exact moment a cluster of secretory diarrhea appears.
Which brings us to a final thought. The laboratory bench is quite literally the ultimate first line of defense. By understanding the intricate mechanisms of the gut, we can identify exactly how it's being attacked. So I want to leave you with this. How can improving our diagnostic surveillance at the microscopic level help stop the next global outbreak before it even starts? Thank you for joining me for this explainer. Keep questioning, keep learning.